Good afternoon. Just wanted to remind everyone that at noon you may hear a siren. You don't have to duck under your tables. It's a testing of our warning system for tornadoes. With that, our next speaker is Brittany Hayes, who's going to give us an overview of the mental health policy landscape in Oklahoma. She's the Director of Policy Research and Engagement at the Healthy Minds Policy Initiative. Brittany.
And we'll be sure to unmute and start video so our friends online can also see.
Do we need to turn down the volume a bit?
This part's working. Well, no. Okay. All good? All right, so I should talk closer here. We're going to be talking a little bit about the mental health policy landscape in Oklahoma, but to contextualize that, we'll also be talking a little bit about what's happening at the federal level and inspiration that we can draw from other states here in Oklahoma. We're going to be talking primarily in 3 different areas. If we wanted to talk about mental health policy, we could probably be here for a couple of days, but we're really going to hone it down into integrated care, so more inclusive than just the collaborative care model, the workforce issues going on around the country and in Oklahoma, and then finally on mental health parity. So when we talk about the delivery of behavioral health care services, particularly in a primary care setting, we ask ourselves, why integrated care? What are the benefits that we get? And we know, because you're sitting in this room, that you know what those are. But one thing that we know from research is that only 47% of cases of depression are detected in primary care. Only 24% of primary care patients with depression are treated, and only 9% of primary care patients with depression are treated adequately. So it kind of gives us the overarching view of why integrated care really begins to matter. 56.6% of Oklahomans with a need for mental health treatment in 2022 did not get help. 45% of people who died by suicide had contact with a primary care provider in the last month of their lives. And Oklahoma's per capita supply of primary care physicians is more than 1.5 times that of the national rate. So when we talk about the development of primary care, and we'll talk about this a little bit on workforce as well, the PMTC, the Physician Manpower Training Commission, did phenomenal. We can look at Oklahoma and that program as really the gold star of getting providers to Oklahoma and then getting Oklahomans to those providers. So here are a couple of policy changes on integrated care. First, starting at the federal level, the Biden administration in particular has really been a fan of integrated care and collaborative care in particular. In 2021, we had the introduction of HR 5218, which was the introduction of Collaborate in an Orderly and Cohesive Manner Act. I do not wish that Oklahoma named bills like this, because this really tells you nothing about what the bill would have done. But essentially what it would have done was increase the Medicare reimbursement for collaborative care. And what that would do is allow for practices and clinicians to adopt the model. Like Dr. Kate talked about, there are infrastructure costs. There are costs to the way that the practice runs. Unfortunately, this bill did die. It was a swift death, but it was reintroduced in 2023, about 2 weeks ago, with the Complete Care Act. And the Complete Care Act goes a little bit farther. I won't even pretend to remember what the acronym stands for, but essentially it's also about collaborative and integrated care. Along with increasing the Medicare reimbursement rate to 175% of its current rate, it would also create a grant-funded program for practices to apply for additional funding from. So if you really needed to create a cloud network, if you really wanted to upgrade that HIE, we know that we have clinicians in Oklahoma who still use paper files. If they wanted to apply for that funding to really upgrade their practice, that's what that grant funding would be for. Like I said, it was introduced September 28th, so there's been no movement on it so far. But if you are tracking what's happening with collaborative care and integrated care at the federal level, that's what you would be watching out for. In Oklahoma, we had a great year talking about collaborative care. Every legislator that we talked to was really receptive, particularly because we're such a rural and frontier state. that the idea that there's not suddenly going to be tens of psychiatrists in rural Oklahoma. And I say tens because there just aren't that many to begin with. So one thing that happened was the legislature passed and the governor signed Senate Bill 444. Senate Bill 444 required Medicaid and commercial insurers to cover a particular set of integrated care codes. The first set of codes were the collaborative care codes, and the last code is the code that we refer to as the general BHI code, or the general behavioral health integration code. So where is that now? Obviously, the bill doesn't go into effect until November 1st, but there are a lot of steps to get from bill passage and signing to the requirement for Medicaid to cover the codes. When we talked to commercial insurers, they said that they're all covering the codes, but no one's using them. So it was interesting to hear their perspective. But we also know that the coverage of those codes, the reimbursement, is incredibly low. So there's also not an incentive to use the codes, despite them being open on the commercial side. In order for Medicaid to open a code, essentially what has to happen is there's a rate setting hearing. Luckily, we were not subject to the rate setting hearing because it's a physician who's billing. So they're going according to the physician's fee schedule. This is good in the way that we get to skip the whole rate setting process, which could take months, but bad in the way that we couldn't negotiate for the full Medicare rate. So essentially, when collaborative care is open, the reimbursement is about 92% of the Medicare rate. And that rate depends on the particular code that you're using. The point in the process that we are now is the rule drafting. So Dr. Kate talked about CMS rules around collaborative care. When a state chooses to adopt and open those codes, they have their own rulemaking process. So they'll take the codes, they will decide what they're going to cover for who, what the exclusions are, and what the rules are that practices have to follow in order to claim that reimbursement. That's the part that they're doing now. They're drafting. Because SB 444 was a statutory action, that means once those rules are drafted, then they're emergency rules, which means they automatically go into effect. Generally, if it's a standard rulemaking process, then you go through having to make comments and then it going back to the agency and the agency making edits based on what the comments were. So in conversations with the healthcare authority, I mean, the codes could be turned on by the end of the year, but that only gets us so far. My partner over here, Jessica, talks a lot about implementation. I talk a lot about policy. So we're sort of working on what that looks like in Oklahoma, but the codes will be open soon. Reimbursement is as good as you could sort of hope in a state like Oklahoma, where nothing is 100% of Medicare. And that's not a knock on the healthcare authority. It's just the state of healthcare delivery in Oklahoma. So as we begin to see the codes open, that's when practices are really going to start considering if this is right for them. On that behavioral health integration code, which really brings in different types of practitioners like psychologists, there will be a rate setting hearing and then there will be subsequent rules. So the process for that particular code opening looks a little bit different and will take a little bit longer, but it's coming. So we're really excited to be one of half of the states that has the requirement that Medicaid have the code open. Around the country, what's happening. So in Arizona this year in their legislative session, they passed a $1 million collaborative care uptake fund. So similar to like I talked about with the Complete Act, they opened $1 million for their clinicians to apply for funding to either update their practices, update their EHRs, or just get ready to deliver the model. And that really shows the state's investment and belief in what collaborative care can do in their state, particularly because they also have a lot of rural individuals in their state. The next highlight is Missouri. So as you all are aware, we're moving service delivery systems for our expansion population to managed care. Collaborative care is really popular with a lot of managed care organizations because they see the cost savings. The delivery of services in the primary care setting is far less expensive than the delivery of services in emergency departments. So in states like Missouri, we actually see reimbursement rates higher than what Medicare has set them at. And it also brings the opportunity for us I'm not a provider, I'm a lawyer, you as clinicians to really talk to these third-party entities and say, we know that collaborative care works. There are over 90 studies that show it. what can we do to get some sort of incentive for providing these services in the state of Oklahoma? Managed care brings a kind of flexibility to the delivery of service for the Medicaid population that we haven't had before. And it's really an opportunity to begin to open those conversations. We also know that as part of the managed care legislation that passed a couple of years ago, by the end of the 4th year of service delivery, 11% of medical expenditures by managed care organizations have to be in the primary care setting. Like, what an awesome opportunity to bring in collaborative care when we know they have to spend 11% of all of those expenditures in the primary care setting. It gives them flexibility because it helps them meet that benchmark, and it gives the incentive for physicians to have those conversations and leverage that requirement with the managed care entities that they're talking to. So I think those bring really cool opportunities. And built into the managed care system, there are also the opportunity for incentive programs for the healthcare authority to organize. And so those are conversations that hopefully we'll be having in the future with the support of folks who are continuing and starting to deliver collaborative care in the state. Oklahoma's workforce. So one of the issues that we really focus on at Healthy Minds is workforce. I think that collaborative care is a great use of Oklahoma's workforce, but a lot of folks, particularly those not working in mental health, don't really know the specifics of what's going on. So here you can see our yellow line is the HRSA line. So this is how many providers HRSA would recommend. The green is the national supply, and the blue is the state supply. I know you're all looking at LPCs. We'll get there. We're just not there yet. So if we look at licensed clinical social workers, we're far below both the national supply and the HRSA recommendation. If you look at psychologists, we are far below the HRSA recommended levels and the national supply. And in our licensed marriage and family therapists, our LMFTs, I mean, we're close, but also still really far away from those recommendations. And then we get to licensed professional counselors, and we think, why do we have so many? Where are they? And how do we have a workforce crisis if this line is so long? There are a couple of different reasons. First, reimbursements are really low in Oklahoma. So until CCBHCs, our certified community behavioral health clinics, came on the scene, a lot of LPCs really couldn't make it. Like, it wasn't a paycheck to paycheck situation. Reimbursements were so low that even if they had a full slate of patients, they weren't able to take care of their families and children. And so they found someplace else to go. I say that as a former Oklahoma teacher who went to law school. I still have my license, but the LPC board doesn't really ask LPCs if they're using the license that they hold. So that's something that we would like to see in the future. It's great that we have this many, but if they're not practicing, doesn't really count, right? All it really does is skew the data to show Oklahoma as number 4 in the number of providers that we have. And so we have LPCs. How can we integrate them back into healthcare delivery? How can we bring them back into the fold? Because that's one way that we can alleviate the workforce crisis that Oklahoma is experiencing. But what else is going on in workforce? At the federal level, Medicare has recently expanded the type of provider that they will reimburse. In 2023, that included social workers. Starting January 1 of 2024, that will include our licensed marriage and family therapists. So that will help particularly our older adult population. Older adults now are experiencing more mental health conditions than they have in recent years. Primarily, I mean, didn't start with the pandemic. The pandemic exacerbated it. But it's great to see Medicare taking on a different provider type. HRSA also has a federal budget proposal for the investment in the behavioral health workforce. So this is happening at a federal level, which would eventually trickle down for Oklahoma to apply likely for grant dollars to support workforce initiatives in Oklahoma. Particularly in Oklahoma, we have become interested in interstate compacts. Interstate compacts allow providers who are licensed in Oklahoma and another state to work in either state. That's really great in the states that have good reimbursement rates. It has a potential downside in Oklahoma. If you are a licensed psychologist who recently got their compact passed in Oklahoma, and you're big numbers, and your reimbursement rate is $120 in the other state that you have a license and $75 in Oklahoma, of course, you're going to provide great care to people in both states, but $120 is a lot more attractive than the $75 that you would get reimbursed for paying for or for providing services to somebody in Oklahoma. So it's always something to think about. Our licensed professional counselor compact goes into effect on November 1st of this year. And then next year, there will be conversations about a compact for social workers. If everything pans out on the national level. Still lots of conversations, but I would anticipate seeing a social work compact come in the next couple of years. The other thing that we're seeing, just a primary example, is House Bill 2175, which created the Behavioral Health and Workforce Development Fund. One of the ways that we know we can really bolster our workforce is by keeping those who study in Oklahoma in Oklahoma. We can do this by increasing the number of psychiatric residencies we have. We can do this by mental health loan repayment, so really repaying those people. If we're talking about upskilling, so think of a caseworker who has a bachelor's degree, tuition assistance is another mechanism that we can keep people in Oklahoma. And there are also opportunities to bring people to Oklahoma. Unfortunately, this fund did not receive an appropriation. There was an appropriation to another bill that created a workforce development at the Oklahoma State University Medical Authority. It's a one-time appropriation of $1 million that providers in that area who work and operate in Tulsa can apply for to either upskill individuals, add the number of behavioral health providers that they have, add a psychiatric residency if that's what works for you. And that RFP will open soon. So what we're seeing across the country is a little bit different. We have states in various parts with varying different opinions about behavioral health, investing millions of dollars into their behavioral health system. I will say Oklahoma did allocate ARPA money. If you all remember ARPA a couple of years ago to some behavioral health initiatives, but all of that is like one-time funding. We're not seeing a continuous stream of funds for practices or clinicians to apply for to support them staying in Oklahoma. Around the country, in Idaho, one of their priorities has been state agency coordination. We know at the Department of Health, there's some loan repayment. We know at the Department of Mental Health, there's the opportunity for loan repayment. And these folks are so busy that they don't have the opportunity to collaborate, or sometimes they might not choose to collaborate. But Idaho is starting to require state agency coordination on workforce. A couple of years ago, the Office of Management and Enterprise Services released a study about Oklahoma's workforce, and one of their recommendations was cross-agency coordination so that we have a better idea of what our workforce is doing. And it's not just what's happening at the licensing boards, right? It's what's happening in higher ed. How many people do we have applying to enter these programs so that we can anticipate how many people are coming out of these programs? But we're not thinking of this as a linear issue, right? Of this workforce pipeline. We're really thinking of it as it's your fault that we don't have enough psychiatric residencies, or it's your fault that we don't have enough internships, or it's the federal government's fault because we don't reimburse our interns' time when they're providing services. And an opportunity for state agency coordination allows a venue for those sorts of conversations to happen. In Ohio, they recently invested, I think it was $18 million in training pipelines, right? And their focus was really upskilling folks like peer support specialists and case managers to get them to be master's level clinicians. There's a lot of interest in working in the mental health space, but there's less investment and really changing that interest into those people investing their careers in this space. It definitely helps that Oklahoma has CCBHCs, or those certified community behavioral health centers, because it's brought more revenue in and it's allowed for the increases of salaries. And that's great for that particular service delivery model. But when we talk about private providers, it really begins to squeeze individuals out, particularly in rural areas, who are solos, right? And it's great to talk about Medicaid and the Department of Mental Health, but those aren't the only mental health practitioners that we have. And so talking about training and upskilling opportunities, or even looking at things like career tech, right? I taught at a semi-rural school, suburban school, but half of my students went to career tech. They had one health opportunity, and it was a CNA. There was no other opportunity for a student who wanted to transition into behavioral health to really seek that path. And the last one is mental health parity. How many of you have heard of mental health parity? sort of an abstract federal law that passed like the year that I graduated high school, and still it feels like not much has happened with it. One of our big focus areas, and probably my biggest focus area, is mental health parity. One of the things that we did in 2023 was look at network adequacy. So what we did is we took a couple of different network directories of some of the biggest plans in Oklahoma, and we said, how easy is it to not only contact these folks, but then to schedule an appointment with them? Turns out, not very easy. As you can see here, only 60% of the 40 providers interviewed could offer information about their wait times. Only 33% were able to offer an appointment within a month, and only 18% could offer an appointment within a week. Within this study, our major findings included that many of the providers appeared unreachable. They would have disconnected phone lines. There have been instances around the country of network directories containing providers who had passed on. That's not very helpful for scheduling an appointment. And we also found that networks have gaps in rural areas and in specialties. If you needed a cardiothoracic surgeon, I guarantee you your health plan has one in it. If you needed a child psychiatrist who focused on sociopathy, you could not find one. There's probably one in the state of Oklahoma, but they just might not be in your network. So one of the things that we're finding, particularly in the context of behavioral health, is there are whole swaths of providers that aren't included in those conversations. And there are opportunities to do one-off contracts for services for existing patients or complex cases, but that becomes overly burdensome, not only for the insurer to maintain that contract, but also for the provider, who, if they're seeing one patient who has similar conditions, it's probably most of their patients if they are specializing. And to focus on this last finding about networks leave out most providers, when we looked at those directories and compared them to the licensure boards, what we found is that the most robust network in terms of mental health only had 30% of licensed behavioral folks in it. Where are the 70%? Of course, like, you've got some working in the public system and CCBHCs, and you've got this really high number of LPCs that we can't really clean the data with. But where are the rest of them? Why aren't they in network? Is it just reimbursement rates? Is it something else? Is it the relationship between the insurer and the provider? Lots of questions and things to think about. But at the end of the day, the finding was that nearly 2 million Oklahomans with commercial insurance have unreliable and inaccessible coverage for mental health through their health plans. Here is just another visual. So about 40%, we contacted 4 or more providers before getting an appointment. On the physical health side, about 14 or 15% contacted 10 or more providers before getting an appointment, 10% of those looking for behavioral health appointments versus 1 or 2% looking for physical health appointments. So what we're continually seeing, sorry, I get distracted by the comments. We are working and talking about psychiatric nurse practitioners. Those programs are expanding in Oklahoma, and we're really excited about that, particularly because one of the issues on workforce is we don't have enough providers with prescriptive authority, and under supervision, those folks would have that authority. So parity, where is it going? Where has it been? I will say that the difference between what was happening with parity in 2019 and what is happening with parity today is completely different. And I'm proud to say that Oklahoma is actually ahead of a lot of states in how we approach mental health parity, particularly for the size of state that we are. On the federal level, in July, there were new proposed administrative rules. Essentially what happened is the Mental Health Parity Act was passed in 2008, and everybody said, this is really confusing. We don't know how to show you that we're providing mental health services in parity with medical surgical services. And then in 2021, with the Appropriations Act, the federal government said, we hear you, here are better regulations, and actually write out a comparative analysis of what that looks like. In layman's terms, imagine you're doing a word problem with your kid at school, and they don't want to show their work. They just say, I promise that my answer is 8. The federal government said, it's not going to work, right? You have to show us, write out, compare. And you're thinking, well, what are these networks supposed to compare? I promise, this will hopefully be the only part that I go into the weeds. There are things called quantitative treatment limitations. So imagine, what is your copay? What's your deductible? Well, it's really easy to look down a list and say, okay, my med-surg benefits, my mental health benefits. Well, one says my copay is $75 and my copay on the other is $15. Obviously, those things are unequal. The really confusing part gets to non-quantitative treatment limitations, or NQTLs. And as far as I'll go is to say, a lot of it has to do with how we're utilizing things that you can't numerically measure, like pre-authorization. So for example, there was a case filed in 2014 in California that got its first ruling in 2019 and then is still on appeal in 2023. So if you think that like medical systems move slow, the laws got you challenged, right? We move just as slow. And it's essentially said that, and one of the findings of the court was that when we looked at pre-authorizations on the med-surg side, there was far less scrutiny when a claim was made. On the behavioral health side, there was a lot more scrutiny. We were pulling more claims, reviewing more claims, and the court said that's what violates parity. Now, if you get really into this, the Witt case is more about another type of federal law than it is parity, but it does a really good job of examining what it looks like to cover services in parity, mental health services in parity with physical health services. So these administrative rules aim to clear up some of the even more questions that carriers have. And I will not pretend that this is easy. Like, providing and writing these reports is really, really difficult. But at the end of the day, it's what helps show that we're delivering mental health services in the way that we should be. I mean, I think compliance is fun. I understand rarely anybody else does, but it's only through these processes that we figure out whether or not we're fulfilling the promise to the beneficiaries that their plans are doing what they're buying into them to do. The other interesting thing, we know Oklahoma is transitioning to managed care. Well, under our Medicaid fee-for-service system, there was no analysis of mental health parity. It wasn't required by federal law. Now, our expansion population, largely who will be served by managed care, now has the responsibility to provide services in parity. And you can look in the RFP, and I anticipate you can look in the contracts, and it says, we will follow parity. That's great. Let me see, right? Like, give me the reports. How are we doing this? What does it look like? How are you accomplishing these things? So right now, under federal law, the healthcare authority would say they're following parity and here's how they're doing it. Some states approach it a little bit different. So in Oklahoma, all of our commercial plans have to submit comparative analyses on mental health parity to our insurance commissioner every year, like clockwork. In some states, it requires those managed care entities to create those comparative analyses so that the healthcare authority and the insurance department also have them on the yearly basis. Because when CMS looks at them, they say, hey, you've got 30 days, turn in your homework at the end of the 30 days, and then we'll look at it, right? You see the difference. One is more proactive to say, we want to make sure this is happening. The other is reactive, either because CMS requests it or because the Department of Labor has gotten so many complaints that they're like, okay, let's go ahead and see it. Like, we've heard about you. Let's make sure that you're actually following the rules. So CMS put out a request for comment 4 or 5 days ago to say, how should we be doing these things? What do you want us to look for? If you all recall, when the ACA passed in 2008, Oklahoma said, we need help with this. Like, we don't have the infrastructure, we don't have the capacity. And that's sort of the relationship that Oklahoma has with CMS on parity now. We have a parity law, we have a couple of parity laws in Oklahoma, but none of them have enforcement mechanisms, very strategically, because why are you going to punish somebody if nobody knows the rules? But we'll talk about parity enforcement a little bit further down. So that's what's going on at the federal level. It's a lot. At the end of July, they released like 700 pages of guidance. It was a really fun weekend. And we'll see what happens. The comments are due, if you're interested, on October 22nd for the proposed administrative rules by the Department of Labor and December 2nd for CMS. In Oklahoma, we passed Senate Bill 254, which is our timely access law. That essentially says that depending on the level of need that you have or the type of appointment that you're seeking, it requires insurers, after you notify them that you can't provide a provider, that you can't find a provider and they can't send you to one, you can go out of network without paying the additional cost sharing. This doesn't go into effect until November. There's also a reporting requirement, so we'll know hopefully at the end of next year, how many people are utilizing this. Potentially it could be 2. We don't know. All we know is that we've heard time and time again, I can't find a timely appointment. And you're thinking like, what's timely? For acute care hospitalization, 24 hours, for inpatient hospitalization, 2 days, and for an outpatient appointment, 30 days. And you might be saying, those are really, really long wait times. And I would say the only other state that has a law like this is California. So we're doing what we can. But that's what happened in 254. The next one was Senate Bill 442, and that's directory accuracy. How many of you have like honestly looked at your plan and the directory that they offer? That's what I thought. But I will also say for a lot of these plans, the directory looks a lot more robust than it might actually be. We're talking inaccurate providers, wrong addresses, wrong phone numbers, and there's definitely a responsibility between the carrier and the provider to keep that information updated. It's not a one-way street. If you moved offices, Blue Cross isn't going to know that unless you tell them or unless they ask and you respond, right? Like, it's only fair that if you move, then it's possible that the directory is inaccurate. That also disadvantages you in some way for those people who actually do look at the directories. So this new law says that the directories have to be updated at statutorily required times. And if somebody relies on a directory that is inaccurate, you can go to the insurance department, and if it is the carrier's fault, the insurer's fault, then they can be responsible for the difference between if you would have gone to an in-network provider and ended up relying on and going to an out-of-network provider. There are a lot of notice requirements. You got to talk to your insurer. You got to talk to the insurance department. This isn't an opportunity to go see a doctor that you know is out of network just because you heard about them or they were on Oprah. Is Oprah? I don't even know if Oprah's even on. It's not an opportunity to do that. It's really for those folks, particularly who are needing child psychiatry services who can't get in anywhere. They don't have a psychiatrist in their network. It's an opportunity for them to have that conversation with their insurer and say, it's not in my directory. They're not in my network. We really need these services. What can we do? The other thing too, is we talk about workforces. If the carrier is required to build a relationship with the provider for that one person, we're hoping that that's a relationship that goes beyond that one person, that they begin having a conversation about entering the network and sort of helping fulfill those network adequacy requirements. So what's happening a lot around the country? A lot. You'll see in places like Michigan and Georgia, they're really dealing with generally accepted standards of care, particularly in the context of like medicated assisted treatment or anything that has to do with substance. They call it substance abuse. So in this context, I will call it substance abuse. I generally would not. Following standards of care according to ASAM. So if you're in Illinois or New Hampshire or California and you're looking at medical necessity and the generally accepted standards of care, if the law doesn't speak to it, then the carrier can define it as long as their interpretation is reasonable. It's like my least favorite word in the legal context, but if they are reasonably understanding what those accepted standards of care are, then that's all the services that they have to deliver. I mentioned a couple slides ago the WIC case. Essentially what happened there is they had their own generally accepted standards of care, but what was happening is they were defining only acute care. So if it didn't fall under acute care, so any follow-up care after acute care wasn't covered because that was how they defined their generally accepted standards of care. No other carrier that I know of does that anymore because of the WIC case, which is still going on. But that's one thing that a lot of states are looking at is controlling the narrative on what standards are we applying. And in the case of substance use, ASAM is the perfect sort of guideline, right? It's created by physicians and clinicians. Everybody sort of understands the tenets, and it's easy in those states to go ahead and put that into statute. The last one is parity enforcement. I honestly changed this line this morning because yesterday in California, Kaiser Permanente ended up getting a $200 million fine for violating parity. It's not going to happen in Oklahoma. Like, we don't have that many people. Our plans aren't that big, but just an example of what's going on. Federal parity laws are sometimes adopted by states, like in Oklahoma, so that they can apply them to their own carriers that aren't ERISA plans, which you don't need to know what it is. It's just the word that's percolating in my head. So states can have the authority to enforce parity if they put it on their books. That's what's happening in California and Illinois. By comparison, the fines in Illinois are like between 25 and 75,000, depending on what the violation is. So states really control their own destiny in how parity is applied and enforced. But I think that is it, unless you all have questions. Sure. So the parity comments from the Department of Labor are due October 22nd, and the CMS comments are due December 2nd.
I do have a question. You mentioned the term comprehensive community health center, mental health center. Yes. Could you, that is something that I've heard about relatively recently within the last year and not real familiar with that whole concept. How is that unique to Oklahoma?
Oh, in a couple of different ways. Okay. Focus. 2 minutes. So certified community behavioral health centers were an initiative of the Substance Abuse and Mental Health Administration from the federal government. Oklahoma was one of the 3 states that really started or got the initial grants to be CCBHCs. And the difference between a CCBHC and a CMHC, one, CMHCs are generally fee for service, right? So you see a person 4 times a week, that wouldn't happen. If you see a person 4 times a month, then you're going to claim by claim for that person. In a CCBHC, it is a value-based care model. So you're going to get a certain amount of money per member per month to deliver those services, knowing that some people aren't going to cost you that full amount of money, and other people are going to cost you a whole heck of a lot more than that amount of money. And hopefully it evens out. So far, it has. The other difference too, particularly when thinking in the context of primary care, is CCBHCs also offer primary care services. It just happens to be that a lot of the people who would be enrolled in them have a primary diagnosis of a mental health disorder, but need primary care support. So think of things like diabetes maintenance or medication management on the physical healthcare side. So when we're talking in the context of collaborative care, a lot of these folks will have their primary need would be a primary care doctor with the addendum of mental health services. Somebody being served by CCBHC would have mental health as their primary diagnosis, but would also need access to a primary care doctor.